This week on the Back Table Podcast.
One, I was also experiencing motor block. And actually, I told you that when I started, I didn't have a lot of experience, like practical experience with these. I mean, I'd read some papers and, everything in the textbooks that I could get my hands on before I started these. But man, it must have been one of my first 6 months. I had a motor block, and it was certainly made me very nervous. Like, I knew it was something that could happen, but until it actually happens to you, it's hard to know like how you react to it. And my mind went to all the worst things that could have happened. And my patient, there are different patients that it can happen to, and it couldn't have happened to a better patient. I mean, the guy was a complete prince. I remember after we did the procedure, I came and checked on him afterwards and said, "How you doing?" He goes, "I'm great." He goes, "I feel fantastic." He was an old guy. And I was like, "All right, well, good. Well, we always did these on a Friday." I said, "We'll have a nice weekend." He goes, "The only thing is, can't move my legs." I was,
Yeah.
And he just mentioned it as if in passing,
just in passing.
And he had to hang around for a little bit afterwards until it wore off. But it took about 3 or 4 hours before I was comfortable turning him loose.
Hello, everyone, and welcome to the Back Table MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the spine jack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show.
Hello, everyone. Welcome back to the Back Table MSK Podcast. Today we have a Back Table Basics episode, and I'm joined by my friend and colleague, Chris Beck. We're coming at you live, not actually live, from Dallas, Texas, and Paris. And that's Paris, France, not Paris, Texas, for anybody keeping track. Chris, how are you, man?
Good. Jacob, thanks for having me on the Back Table MSK show. Long-time listener, first-time guest. So appreciate it, man. I love the show. Actually, I don't know how many of your audience members know that you did the intro music. That's Jacob Fleming original.
Oh, God. Aaron asked me, he was like, "Hey, do you want credit at the end of the show for that?" And I was like, "No,
of course,
I just kind of want it to be anonymous." But now the cat's out of the bag.
Easter egg for those hardcore fans.
So today we're going to be talking about a very important topic, epidural steroid injections. And I think this is going to be fun for us and our listeners because your perspective is coming at it as an interventional radiologist who kind of had to learn to do them out of necessity without really much, if any, exposure in fellowship. And I've just finished my own fellowship, which is very spine focused, and did several hundred epidurals. And so I'd really like to share our tips and tricks and different approaches. And one thing that I found with these is there are many different ways to skin a cat. And so I think we can talk about the different techniques and maybe some pearls. And so why don't we just jump in? We'll start with some talk about lumbar. And just tell me what's kind of been your experience with ESIs?
Yeah, you kind of nailed it in that went through fellowship. I was, classically interventional trained in kind of the old model in which I did diagnostic radiology for 4 years and then 1 year of fellowship. And I did a total of 0 epidural steroid injections. I did have a little bit of exposure in residency. We had a diagnostic neuro rad who would, just when you were on a neuro rotation, you might do some. So maybe I had done 20 or 30, somewhere the kind of a relatively low number, definitely under 50, but didn't really conceptually understand a lot of the times what I was doing because it was so spotty. I just wasn't doing them with a lot of reps. And then when I get out, I took a private practice job, and the role that I stepped into, there was a lot of bread and butter interventional radiology, but then there was all these things that were just little add-ons. And one of them was we had kind of a small pain service, but it comprised maybe 10% of the practice because we'd reserve one Friday morning. We had a little OBL that was attached to the hospital where we would do all of our pain procedures, which was like joint injections, back injections. Some of the other guys were doing medial bundle branch block and ablations. And so I kind of fell into this practice where I had to learn it quickly. And we also had a practice where, they kind of put you out on an island and it was like, swim. Hold on, is that the expression? They just put you out okay, I don't know if that's it, but they put you out on an island and you were expected to like be able to do these procedures and do them quickly. Like there wasn't a lot of shadowing involved. So, and then, now it's 10 years later and it's a procedure I feel very comfortable with, but I didn't have an academic approach to like coming at these procedures. It's just something I had to learn on the go. And then I've kind of developed my own like way of like working or kind of navigating these patients with our referral patterns, which we'll kind of get into talk about too.
Yeah, for sure. My experience in residency, I think, was somewhat similar to yours. We had a pretty robust neuroradiology spine service, and which performed, the bulk of the work was definitely like LPs, intrathecal chemo, and myelograms, but did a pretty decent amount of both targeted and non-targeted blood patches. And ESIs would come along kind of once in a blue moon. But so many of those procedures were done under CT. And so that's an approach I became very familiar with. But I will say now to our radiology colleagues who are listening to this, because no other specialty uses CTs for ESIs, I will say that, in my opinion, fluoro is far and away the superior option. It's quicker. And I don't really care too much for doing those injections under CT because you're committed to doing just a straight axial approach unless you can tilt the gantry. And for me, having a bit of an angle with the ESIs is something that's just really, really important and just makes it more versatile. So why don't you kind of walk us through, first of all, what are the most common kind of patients you're getting ESIs for?
So I think we have like a nice patient mix in that we get a lot of referral from like an orthopedic group. And I think there's a couple spine surgeons and a lot of orthopedists. And so a lot of these patients like have like a pretty good workup coming in. Like I think we have like a good patient mix in that it's patients who are interested in conservative therapy. They're either passing on a surgery or aren't surgical candidates. And so they come with a lot of openness to like epidural steroid injections. And they've already been briefed on it pretty substantially. And then we get some referrals from like the community where we do a little bit more legwork on the beginning. And, our referrals can be all over the map in that like sometimes the spine surgeons want a specific level, specific number of injections. Like they can be very prescriptive about it to, maybe one of the other orthopedics who does a lot of hips or something. He's just like, I just want to like try and tease apart whether it's a back issue or a hip issue. And they give us a lot of leeway. They, just say, look at the, just do your workup and go through the motions of like seeing the patient, looking at the imaging, and then choosing the level that we think is most appropriate. So we have I think we have a nice mix. That's been like a fun patient population to practice on.
Yeah, I agree. And so my fellowship, like I said, was probably about 85-90% spine related. But as you alluded to, a lot of these patients come in and they have leg pain, right? They've got, sciatica, and a lot of them attribute it to their hip or their knee because referral patterns can be complicated. And so I think this is something that's always worthwhile to keep in mind. And it really comes down to, in my opinion, the MRI, the lumbar spine, kind of figuring out where you're going to go and what is actually causing it. And one of the nice things about the ESI is it is a diagnostic tool as well. And so you can get pretty quick feedback on whether you targeted the right level of pathology. Although I will say that most ESIs are actually they're not very selective per level. And that's something that we can get into. But the indications for lumbar epidural steroid injections would be lower extremity radiculopathy with or without back pain. And so notice that back pain alone is not a very good indication for ESI. And those of us who have done it know that for just solely axial back pain, you might get a little bit of relief, but it typically doesn't last. It's definitely not a good durable treatment. And then spinal stenosis is another one. I look at that more of a diagnostic tool to figure out if their neurogenic claudication is coming from that particular area. Usually there's not a whole lot of doubt about it, but kind of prepare the patient that with any of these injections, it's hard to say, the durability of the relief that you'll get. You'll certainly get some, and we'll know today if that's the right switch. But it could last for 2 hours, could last for 2 years, and it's very difficult to approach this. So, for example, my dad needed just a simple ESI. He's got some stenosis, had fairly significant neurogenic claudication, and now 7 months later, he's still fine. So it's extremely variable, I find. But so those are kind of the indications we talk about. I think at some other point, you alluded to medial branch blocks and facet interventions and disc injections. I'll just kind of put the solely back pain off the table for now and say we'll cover that at some other point. And so tell me about, you've got ESI on the schedule today. Patients, you've talked to the patient already. And so patients on the table, just run me through your technique, how you take care of this.
Oh, one other thing I wanted to touch on, I just wanted to drill down on it, but you did a good job in talking about just the reasons patients were referred. I do the two categories. I'm always trying to put patients in a box to choose what kind of procedure I'm going to do. I try and select the patients who are primarily neurogenic claudication, and those are the ones I'm primarily thinking, let's start with interlaminar injections, and then the patients who are primarily radicular symptoms. And sometimes, everyone who treats back pain knows that this is kind of a messy category, but I really kind of drill down with my patients, do some targeted H&P and some physical exam maneuvers to try and tease those two apart. Or if they have both, I'll just ask them, I say, what's bothering you the most? Is it, if I were to take away your leg pain today, is that do you think you could start gardening or riding motorcycles tomorrow? And so that's kind of how I'll start the conversation, with also leaving the door open to my patients and telling them look, let's dig in for the long haul, because back pain is something everything that we do today, it's just to control the symptoms, but all and I just kind of broadly talk about it in broad strokes. So it's all that arthritis, all those pinched nerves, they're still there. So what we're doing is just symptom management. So there's going to be opportunities to try different therapies or try different things to get you dialed in. The other thing I was going to say, kind of my preamble to the procedure, is, I always take pain assessment score. And I think people can get a little bogged down in the numbers, what's your pain score at? What's your pain score at its worst? Whenever it's at its best, whenever you're, whatever. And I always tell them that those numbers are important to me. But what I'm really trying to do is restore them to a certain kind of symptom relief, to where I don't care if they're at a 3 or a 10 or a 6 out of 10. If 3 out of 10 means that they can go do the things that they love to do, like ballroom dancing or jumping out of airplanes, then that's a success. If that number needs to be 2 for them, or if that number needs to be 4 for them, that's the goal of therapy for me, is to chip away at this back pain to where they're going to be able to do the things that they love to do and not be afraid of back pain or radicular symptoms getting in the way of that, lifestyle limiting symptoms. I just wanted to say that.
For sure.
Yeah.
Yeah, for sure. I'm glad you brought that up, because that actually brings up, I think, the differentiation between chronic and more kind of subacute presentation. And so I'm sure you've had these patients who they present and they have just terrible sciatica. And one of the things that I've learned is that sciatica is one of those types of pain that really can be a 10 out of 10. And I put also up there vertebral compression fractures and just a few other things. And so usually when, just a, pretty stand-up citizen comes to you and they're just having terrible pain, there's a very good possibility that it's an acute or subacute disc herniation. And so that could definitely be compressing the nerve in the lateral recess or the foramen. But I will say that my experience so far has been that the vast majority of patients who have radiculopathy do not have any sort of lateral recess or foraminal stenosis. And what I learned that this seemed to be due to, and what Dr. Beal has corroborated, is that the inflammatory mediators that leak out of the disc, even if you just have an annular tear, but not any real significant amount of nucleus expelled, it's the inflammatory mediators that really rile up the surrounding nerve. And so in those patients with a, sort of acute or subacute presentation of a sciatica due to an annular tear or certainly any kind of herniation, a lot of times you can knock it out with a single ESI, because the natural history of these H&Ps is that they will heal on their own. But in the meantime, if the patient can't walk, they can't do anything because their sciatica is so bad, a lot of times you can just kick that out, and it often is enough to kind of get them by. So I think that's a really important consideration too. I find that for more chronic issues, you tend to get a little more temporary relief. But like I said, it's very hard to predict this. It's kind of different patient by patient.
I agree. I usually tell patients, similar to you, this is just talking in broad strokes. Like if I'm just thinking about all my patients as a whole, is I'll say, anywhere between 2 days and 2 years worth of symptom relief, with the average, our average internally within our group is somewhere between 3 and 4 months if we're hitting the right area. And that's like the presumption that I've targeted the correct area and like we land a successful injection. So a lot of caveats there, but I think that it's good expectation management that, you might only get a week worth of symptom relief, and that still gives us some, depending on the situation, it can still give you some, diagnostic information that can help with therapy after that, like things that maybe are not in the IR bag, right?
Yeah, absolutely. And some things that are, and, it's kind of just a sidebar is that, there's kind of this dichotomy that I've heard over and over again is that it's like either injections or surgery. And I think that there's a lot in between there that can be maximized. That's sort of a different subject, but I will say, it depends on your relationship with your referents, especially if they're surgeons. And a lot of times if they're a little more prescriptive about what they're asking for, then, the conversation with the patient can go a little bit differently in terms of what could be the next thing. And most of the time, if a spine surgeon is already involved in their care and is kind of running the ship, I was going to say, look, I'm going to defer to Dr. So-and-so says, we're happy to do anything to help you out. That's a different situation than if the patient is referred directly to us from primary care or another source, and they're kind of like eval and treat. That conversation can go a little bit differently.
Totally agree.
So I jumped the gun a little bit earlier, but let's jump into the technique, the technical. Okay. So patients on the table.
So am I doing an interlaminar or transforaminal?
Yeah, let's talk interlaminar first.
Okay. So interlaminar, patient's prone. I will stand on patient's left. We have a table that can kind of airplane, like tilt side to side, but I usually just start with the patient in the just regular prone position and just take a spot of the back. I'll have looked at their cross-sectional imaging ahead of time, one, to know like the level that I want to target and corroborate that with the symptoms, but also it's helpful to me to know about any like variant anatomy that might be there, like if they have transitional anatomy. And so I just take a spot, kind of identify where I want to be. So I'll do a little level count from the bottom and find the exact location. One of the things that is important for me, and everyone's got their own method, but I'll usually try and flatten out the end plates with a little bit of cranial caudal tilt and like true up the end plates. Like maybe if I'm going L3, L4, then I'm going to true up like the superior end plate of L4, the inferior end plate of L3. But sometimes like I have to throw all that out the window, and then I'm just looking for this little white space where I'm just rocking the II, like either cranial, caudal, and sometimes right to left. Usually, if it's interlaminar, I'll ask the patients, like, just tell me which side's like the worst. If it's dead even, that's fine. I'll just pick a side that I think is easier to get into. But I find that like I always start paramidline and just try and direct it as like towards the center as possible. But that's sometimes easier said than done. Sometimes like a side can be totally blocked off to you. But with a little needle steerage, I can kind of get it close to midline. But if they tell me like pain is mostly right-sided, then I'm going to go right-sided. I also feel like there's a patient like in between the ears component that like, if they tell you all their pain's on the right side or majority's on the right side and they have a bandage on the left side, they're like, they
didn't get the right spot.
Yeah, exactly.
They didn't get into the right epidural space. But no, I totally agree with that. I totally agree with that.
Right. And I understand that.
Yeah. And I think that's totally reasonable too. And I do the same is if there is a laterality to it, then I'll target that. And one thing that I learned during residency really is that if you've ever done these under CT, either ESI or blood patch, you'll see, regardless of where you inject it, it goes everywhere. Yes. Okay. It goes ventral, it goes left, it goes right, it goes up, it goes down. And so for me, the selectivity of the, transforaminal, which we'll get to in a second, it's not too important. But I think, like you said, from the psychological perspective, it's just better, oh yeah, we went on the left side. Oh wow, my leg pain is gone now. But I wouldn't worry too much about that. So if we have, sciatica, just leg pain in both legs, we go from a left-sided approach, you can still expect to get relief bilaterally. But probably the more of the concentration of the medication will be on that laterality.
I agree. And that's a good point to bring up. If you've ever done in CT, you really see like how much coverage you get, both ventral, left, right, dorsal. And so I'm just looking for that like little lighter area, which is like, in between the bony elements. And I'll kind of advance the needle. I use a 20 gauge 2E needle. Sometimes I use a 22 gauge. The kits come with a 22 gauge, but my preference is to use a 20 gauge. I once had an attending who told me, this was in IR fellowship, Keith Horton, although I know he doesn't listen. Keith, if he told me that anything worth sticking with a 22 gauge needle is worth sticking with a 20 gauge needle. I've taken that to heart with whether it's kidneys, liver, or whatever, like abscess drainages. So I usually use 20 gauge. And so I'll just go with a 20 gauge needle. And I used to like direct it at like a posterior element and then kind of walk it down. I've kind of gotten away from that. I'll just go for the clear space. And I have a feel for it when like I'm meeting a little bit of resistance and have a LOR or loss of resistance syringe on the back filled with saline. And I'll just kind of like poke it along. And as soon as I have a little bit of pressure with my thumb on the syringe, and as soon as I feel like it give, then take the LOR syringe off, and the rad tech is rotating the II into the lateral position. And usually before I see, this all kind of happens like, it's kind of like an organized dance, but as they're like putting the II in the lateral position for me, I've already injected contrast. And so my next picture is it in the lateral position, and I can see if I'm epidural or not, which, I also look at the needle, like, am I getting like CSF return, or if I'm getting blood return, but ideally like you just, nothing. And so I do that injection. And once I see like a nice epidurogram, we save that picture in addition to the PA picture. And then I dose, and then I just give the steroids. And for better or for worse, like I'll give the steroids, and I kind of think of like the 2E, like if it's in the 12 o'clock position, if the stylet is, or the bevel is open towards the 12 o'clock, I'll give a little bit in the 12 o'clock, and then I'm rotating at 360 degrees. I'm kind of dosing it in. I would say there's probably some voodoo to that. And every now and then, like there's one clock face that doesn't want to accept it. I don't sweat it. I just keep putting it in. And
Sure.
Wherever it's receiving it normally is where I'm putting the meds.
Gotcha. Do you have a specific cocktail that you prefer?
For interlaminars, I do 30. So it's 5 mLs of Celestone, which is probably 6 mg per ml. So 30 milligrams of Celestone and 1 ml of bupivacaine, 0.25%.
Nice. Yeah, the mixture that I learned in fellowship is a little more inverse of that. So we would typically, in the lumbar, we would typically use Kenalog or triamcinolone. And so that'd be 40 milligrams in 1 cc. We would typically do total injectate volume about 8 cc's. And Dr. Beal's style, which a lot of people are like, what? is for the rest to be 0.25% bupivacaine. And personally, having learned with that, I really like it. And I will say that there are some times where I don't want to give that entire volume of bupivacaine. And certainly, I know that there are some people who, just use saline. Some people use lidocaine. And the good thing about bupivacaine is that it is a much lower concentration than the lidocaine. You can end up with a motor block, and don't ask me how I know that, in certain situations. And I've noticed that to be more common in post-surgical state, even if the patient has had something just like a discectomy at that level. There's still enough kind of post-surgical change between the epidural space and the dura that you have kind of this sort of friable dura. And so it seems to be that you can get sort of a partial spinal block doing that. And so you can get, the patient will be like, you get them off the table and they're like, oh, my legs are really weak. And it's like, okay, it's going to be okay. But as the bupivacaine kind of sets in, and like I said, if you have that sort of partial spinal effect, they can get a temporary motor block there. And that's fine. And it can be concerning for the patient. And you just have to let them know you're not paralyzed. This is the thing that unfortunately happens. It'll be okay in a little bit. Hopefully, most of the time it's within about an hour or so. But I had one that lasted about 6 hours. And the thing that you can really do to help dissipate that, I found, is try to stand up the patient as much as possible. Obviously, you need help to do this. So at least 2 people kind of helping them up and stand up, even for a few seconds at a time. It just, kind of lets that medication kind of settle out a little bit more. And I feel like that can accelerate it a little bit. And the other situation where I would say I would cut the bupivacaine a bit, either with saline or lidocaine, depending on your preference, is significant spinal stenosis, and which is obviously one of the situations we're doing. And so I've gotten to the point where if I can see that, if they've got severe stenosis, personally, I don't typically like going at that level. I'll typically go the level of above. And like we said, it will run down. And that's just because if you're injecting at a stenotic level, it's more difficult. You can definitely you can puncture the dura more easily. If you're doing a nice LOR technique, you shouldn't, but it's certainly within the realm of possibility. And the other thing is when you're injecting at a stenotic level, it can be really painful for the patient, frankly, just because of the volume of the injectate before kind of the local anesthetic or let alone the steroid kicks in. So those are some of the caveats that I learned through experience. As they say, good judgment comes from experience and experience comes from poor judgment. So
well said. One of the things
those are some of the things I learned.
Yeah. So one of the things I want to say, one, I was also experiencing motor block, and actually, I told you that when I started, I didn't have a lot of experience, like practical experience with these. I mean, I'd read some papers and everything in the textbooks that I could get my hands on before I started these. But man, it must have been one of my first 6 months. I had a motor block. And it was certainly made me very nervous. Like I knew it was something that could happen, but until it like actually happens to you, it's hard to know like how you react to it. And like, my mind went to like all the worst things that could have happened. And my patient, like, there are different patients that it can happen to, and it couldn't have happened to a better patient. I mean, the guy was a complete prince. Like I remember after we did the procedure, I came and checked on him afterwards and said, "How you doing?" He goes, "I'm great." He goes, "I feel fantastic." He was an old guy. And I was like, "All right, well, good. Well, we always did these on a Friday." I said, "We'll have a nice weekend." He goes, "The only thing is, can't move my legs." I was,
yeah.
He just like mentioned it like as if in passing, like that.
Just in passing.
And he had to hang around for a little bit afterwards until it wore off. But it took about like 3 or 4 hours before I was comfortable turning him loose. Although, like I think like now that with having the experience that occasionally these things do happen, I could have turned him loose a little bit earlier. And I've never actually. I think that's the first time I've ever heard that, like standing them up. Does it still work if you sit the patient up, or like if you can get them in a wheelchair or something? Or
yeah, so sitting, most of the time they are sitting, and so that's okay. But of course, you get into once you get to the lumbosacral junction towards that area, the kind of flexion you have from sitting, I think, prevents the medication from spreading out more evenly. And so, maybe this is a voodoo kind of thing, but I do feel like just getting gravity involved, getting them upright for even just a few seconds can kind of let that settle out. And that, I would say that's especially true for the stenosis. So we talked about kind of that spinal thing, but you can have motor block even, without prior surgery with stenosis, and patients can be a bit uncomfortable sometimes just from the injection. And I found that if you can get them up and stand them up, obviously if they have any sort of motor block, but if they're just kind of feeling uncomfortable, then but they can still walk, then getting up and walking around a little bit in recovery, obviously with supervision and assistance, can really help that disperse down through the epidural space. And I think that mechanistically makes a lot of sense to me, where the standing up for a motor block, I think for me, maybe that's something that just makes me feel better. But anecdotally, in my N of 2, it does seem to speed the process up a little bit.
I mean, you're clearly more classically trained in these procedures than I was, or than I am. But when it comes to like cauda equina and going at the stenosis level, I totally agree. But actually go at the level below the stenosis. Like if, they have an L3, L4 stenosis, actually try and go lower than that. And I mean, the idea behind it is certainly one, I'll say that those are definitely the patients you can't just blast in the steroid. And actually I'll say like, I think it's usually poor form if you're just like blasting this in like as quickly as you can get the steroid in. It's kind of like a nice control. Like if it feels good, then okay, take it. But that's a real point in the procedure where you can kind of pay attention to your patient. And we do all of ours under moderate sedation. Every now and then there's a player who just wants to be local, which is fantastic and fine with me. But if they're like coming off the table, like you can slow down your injection rate. Like there's no race to get these done. And certainly like I'll do a much slower injection rate for patients who are experiencing some discomfort when I'm going below the level of stenosis. But I just thought like, below, that way, like I'm tackling all the nerves that like are below the level of stenosis. And then maybe and then also assume that some of it is tracking up above the stenosis.
For sure. And I think that works basically equally as well, just going adjacent to either the surgical or the particularly stenotic level. And I agree. We also do the vast majority under moderate, although sometimes we'll do one under local. This might just be if we're having a clinic day and the patient shows up and they have, a very easy issue to just throw an epidural at. Most insurance plans don't require prior auth for an ESI. And so getting them done the same day, even if we don't have, our sedation nurse in the office, we can just do it under local. And, you kind of have to eyeball these patients and get a feel for them. Because, there's some patients who they're not gonna do well under local. Typically white males who are aged 20 to 40.
Biggest wimps.
No offense to you or me, but we are the biggest wimps, just statistically.
I'm above 40, so it's really just you.
But you have the face of a 20-year-old, so it works out.
Thank you.
So, but actually, there's been some interesting research on this that vasovagal episodes happen less often with moderate sedation. So that's one thing that's nice, and especially in those, the super jacked, 25-year-old dude with a big beard comes in, and you're like, yeah, that dude's gonna vagal. And so, I do feel that moderate sedation for me is definitely preferable. But when we talk about the cervicals in a little bit, we'll talk about why going deeper than that, I think, is ill-advised. So I agree, moderate sedation is great. And when pushing in the medication, I totally agree with what you said. It's not a race. So typical patient, I'll probably inject it over a span of 30 seconds to a minute. And I like to let them know, hey, you'll probably feel some weird sensation down your legs. That's normal. And so it's very common to get a paresthesia with the injection of the medication, especially if you're using, lidocaine or bupivacaine in there, which I do. And just tell them that's normal. Some of them get, kind of freaked out by it. The patients who've had multiple injections in the past, they're probably fine. But I just find that the sensation associated with a lot of these things can be very disconcerting for some patients. And so I like to let them know, hey, this is normal, and having them at a level of sedation where they can kind of appreciate what I'm saying helps a lot.
Totally agree.
So we'll say, like, technique-wise, I think my approach is pretty similar to yours, and usually get a little bit of oblique to whichever direction you're going to go from, because that can help open up the interlaminar space. However, I would say that's the way that I learned it, or I was made to learn it, was using just a standard AP view and with no oblique. And that took me a while to understand, and I struggled with that for quite some time. And now I will say, having been forced to do that, it definitely was more versatile and helps me understand the process for example, a spinal cord stimulator. And so Blake previously has talked about this, kind of the approach for how you put in the needle for placing a spinal cord stimulator lead. And I will say that actually most of the time I do an ESI, I do a very similar trajectory to that of an SCS placement. And so for that, I will start with an AP view, do a little bit of craniocaudal tilt first to crisp up the end plates, like you said. And then some patients just don't have a great interlaminar window, and obviously the patients who have degenerative stenosis is almost always related to degenerative disc disease and collapse of the interbody space, and the interlaminar space tends to go with it. And so angulating more caudal gets you more of a view, which makes sense if you think about it. We're kind of coming up from below, and so that helps a lot. And in that case, if I'm not doing any sort of oblique and the interlaminar space is open enough on the straight AP, typically where I will start is around the level of the pedicle below. And so this is something Dr. Beal referred to as the epidural highway. And basically means, and the way I understand this is basically kind of between the pedicles, the medial borders of the pedicles, and basically the lamina below. As long as you go through that path, you have a very good chance of getting into the epidural space. And this allows you to do it without doing an en-fauce technique. And that being said, I think the en-fauce technique, which would be typically what you described, is obliquing it a little bit, opening up the interlaminar window, and then just starting to place the needle down the barrel. I think that's totally fine. I prefer having learned both ways, I will say that I now prefer the way on a direct AP. But it takes a little bit because you have to, unlike the on-FOS approach where you're really just moving in like one axis, so to speak. This one you're moving in like two or three different axes, and so you just kind of have to get your brain used to it. But it's very similar, and Blake made this point too in a recent episode, is that access to the epidural space is kind of a similar angle to how you would access like an artery or a vein for angiogram. And so those in IR, I think, will kind of understand that pretty well. But I think, especially starting out, I would recommend going with more of an on-FOS approach. A shout out I wanted to put out there before we get further and I forget is, I think a really great resource for this is this textbook, Atlas of Image-Guided Spinal Procedures by Furman et al.
I know exactly.
So this is kind of...
the one that you're talking about. It's kind of a reference in the reading room. Yep.
Yeah, and I think this is great. It's a fantastic resource, and it's got great images, and it's very thorough, kind of walking you through, okay, here's your trajectory view and everything. So I would suggest anybody, frankly, any specialty who's going to do a significant amount of interventional spine work, but especially IRs, if you have that, you'll see that, oh, wow, these procedures are fairly straightforward, and you just kind of follow, make sure you understand the imaging and go at it. Most of these procedures are fairly straightforward compared to the other stuff we do. So I would wholeheartedly recommend that one to have as a resource.
Do you ever, so you talked about like the AP projection. Do you ever flip to the lateral projection to see an ejection?
Right, yeah, okay. Absolutely do. Thank you for bringing that up. So personally, the way I would do it is, part of it is kind of by feel, and part of it is, you can be a little more methodical about it by like kind of measuring roughly the distance on the cross-sectional imaging. And then you can know that, okay, I'm going to be, this many, my needle is going to be this many centimeters in before I'm even close to the ligamentum. And so once I get to that point where I'm like, okay, the needle is in a bit, then you can go to the lateral projection. So some people would use the contralateral oblique, and I think there are upsides and downsides to that. I prefer a true lateral. And so what I would do at this point is I would switch off from my loss of resistance syringe. And the way that I've learned this is actually we didn't use a true loss of resistance syringe, which I think is a great instrument to have available. But we would use our contrast syringe. And so a 3 cc contrast syringe. And so you see where you are on lateral, and you're going to start injecting when you're just posterior to the spinolaminar line. So that's the base of the spinous process where it joins with the lamina on the superior aspect. And so you're kind of drawing this line in your mind's eye from the top of the spinolaminar line. And so once you get in there, you're going to feel the resistance. And it took me an embarrassing long time to understand, okay, what the hell is loss of resistance? What is it? And so what we're looking for is that feeling of loss of resistance as you go through the ligamentum flavum. Because typically inside the ligament, the pressure is such that you're not going to be able to inject contrast. And obviously, if you just slam it in, you can get a subligamentous injection. So, go in, and whether you're going to use a real loss of resistance or the combo LOR contrast thing, which I love that. I don't think I'll ever go back, do that, and then you'll get your epidurogram. And so the way that I would do, if you feel really comfortable, and based on where you are, then I think it's fine to start doing the LOR from an AP. But from a true safety perspective, the true lateral, I think, is the way to go. And once you do that, and then you feel the loss of resistance, and then in your case, then set up the contrast, inject it, or in my case, that's the same as the LOR. Then you step on floor and you get the nice epidurogram. And of course, if you have any question, if the patient has real severe stenosis, then you can do this under fluoro too. I would do it. I personally don't do it live in the lumbar, but I would say 99% of the time I am getting lateral view. And then epidurogram has a pretty characteristic appearance, but sometimes it can be like, oh, is that intrathecal? Is it? Right? So I think that's an important thing to talk about. So the true epidurogram that is epidural, you can see that the contrast will pass over the pedicle, right? Whereas the thecal sac does not extend to the pedicle. And so you won't see that so much. And those of us who've done a lot of myelography are pretty comfortable kind of seeing what it looks like. But sometimes, for whatever reason, you get more of a ventral epidurogram. And that can look quite a bit like when you first start injecting for a myelogram. And that can get a little bit tricky. And so in that case, I would say never be shy about putting in more contrast to get a better feel for where you are. And there's a few other characteristic findings. So a subarachnoid pattern will be more of an hourglass kind of shape and goes kind of straight up. Like I said, it doesn't drape over the pedicles as the epidurogram does. And so if you see that nice epidurogram, even from the lateral aspect, and you're in, I think that's fine. If there's ever any question, come back AP, take a look there, and just do not, under any circumstances, inject unless you know where you are for sure. And like I said, because then you definitely will get a motor block, and that the patient will not be happy with you.
Yeah. Let me ask you this. So if you say you're doing your injection, for whatever reason, you end up intrathecal, what's your next step as far as completing the procedure? Do you abandon the procedure, go to a different level? I mean, I've just heard like people are just kind of all over the map in their approach to this. And some people could be very dogmatic, and I'm interested in your take.
Sure. Yeah, it's a really great question. And I've frankly been taught different ways. In residency, it was kind of tight. If you got CSF back while doing an ESI, you got to abort the procedure for the day, call it a day and go home. I don't think that's necessarily true. I would say abandon that level for sure. And go to an adjacent level. So I really don't think that it is the end of the world to get intrathecal, but you need to be aware, and I think it's appropriate to tell the patient about this, that they may have a spinal headache after. And in that case, if they have that and it persists for a few days, I would tell them, look, take Fioricet can actually really help. And just hydration. And most of these dural punctures are going to be just fine without any further intervention. But if after a few days they're still having a spinal headache, blood patch is an easy thing. And we can talk about that some other time, but the access for a blood patch is exactly the same as an ESI. And in that case, I would go at the level where you either presumably or definitely had the dural puncture and do that. So what I learned in my fellowship is that it's not a contraindication to go ahead with the ESI, but go at a different level so that you have much less chance of getting any of that spinal action.
Yeah, I agree with that. But it's strange that I also learned from in training, when I got a little bit of training on these, that like there were some neuro rads who just abandoned the whole process. Like, oh, we got to bring them back on a different day. But my practice currently is like, if for some reason I'm intrathecal, then I'll just take that needle out. And sometimes it's a little bit painful. Like sometimes you can, not often with interlaminars, but sometimes you're working to get into this one spot and then you finally get in and then it doesn't work out. And so you have to drop and do another level. But I think that really
sucks. And another thing that you can do is a transforaminal. That's okay to do. And so that's something I think we should talk about.
That concludes part 1 of our discussion on epidurals. Tune in for our next part where we'll discuss lumbar transforaminal, cervical, and thoracic epidurals. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junwoy Kennebrew.
Thanks again, and see you next time.